Perfect. Good afternoon, everyone. This is Teresa Lee, Director of the Measurement and Reporting. I'd like to welcome you all and thank you for your participation in this webinar today. I hope you can all hear me clearly. If not, just send us a message on the chat area and then we'll correct any audio issues that hopefully will not be encountered, but if they are, we'll correct those. I'd like to first introduce persons who are here with me today. Eileen Witherspoon, our Senior Health Policy Analyst with the Commission, and Miriam Rahman, our Program Manager, is also here. Julie Deppy, Administrative Assistant, is here, as well as representatives from our auditing firm, Advanta Government Services. The Project Manager, Karen Smith, is here, as well as the Lead Audit Manager, Lillian Regal. Just to give you a little background before we get started, the Center for Quality Measurement and Reporting has broad responsibility for quality and performance data collection, monitoring, and public reporting on health plans, long-term care facilities, ambulatory surgery centers, as well as hospitals. We also publicly report our quality and performance information on our consumer-oriented website. It is called the Maryland Healthcare Quality Reports website, and the URL to access the website is healthcarequality.mhcc.maryland.gov. Within our hospital reporting initiative, we report clinical quality metrics, patient experience, and satisfaction data. But a major initiative within our hospital quality reporting initiative is our HAI reporting. Earlier, excuse me.
Just a second. We have two people who said that they couldn't hear us. So, do you want to just wait a moment to see if? Seems like everyone else can hear. You want to keep going?
Okay. If I need to just bring this close, it might be just unique to those two. Okay. Earlier this month, we added MRSA and CAUTI data to the consumer website, and we discussed hospital performance during our October 15th public meeting, commission meeting. Later this year, CDC plans to release its annual state-specific progress report. So we expect additional exposure related to hospital performance on HAI metrics. I think it's worth noting that Maryland hospitals have done very well with CLABSI, reducing CLABSI by over 50%, particularly CLABSIs in ICUs. We've done very well on flu vaccination for hospital staffing. We're now at 98%, which is, I think we're the second highest state in the country. So we're doing really well, but we do have some issues with other areas. CAUTI, I think we're higher than the nation by about 60%, and we may have also some concerns with C. diff. So I wanted to just raise those issues, even though that this data quality review project does not focus on our performance as a state, but of course the data feeds into that performance. So it's very important that we have our the information that we submit through NHSN, that it be accurate. So our presentation outline is on your screen. It includes an introduction and purpose of our project. We will talk a little bit about the data quality review project, summarize statewide findings, and there are some general recommendations that we'd like to share with you. And then we'll stop for a Q&A session at that point, because the first part of this webinar is a very high-level presentation that is designed to provide information not just to infection preventionists, but we've invited finance and quality improvement representatives from each facility to participate in the webinar as well. And we wanted to communicate to everyone where what issues we found with the HAI data, because we believe that it's a process that will require both leadership support as well as various departments to support the infection preventionists if they're to report this information accurately and completely. As you also know, the HAI data submitted through NHSN and the HSCRC administrative data both have financial implications, as the information is used for the HSCRC's QBR initiative as well as the MHACs. The MHAC, of course, uses the HSCRC administrative data, but the QBR project actually utilizes the NHSN HAI data as well. You should also know that we work closely with HSCRC to make sure they're aware of any issues we identify in the data. And we recognize that it's a very complex and constantly changing area, and it creates major challenges for the infection preventionists at hospitals. And we've been working with the infection preventionists for about 8 years now, and recognize that submitting the data through NHSN, adhering to and complying with definitions and protocols, and the changes that are made very frequently in those definitions and protocols, as well as the challenges of submitting and gathering data in response to our auditing component. We recognize that that can be a challenge, and we hope that they can get the support from the various departments within the facility. So let me first talk a little bit about the project structure. Of course, we have a contractor, Advanta Government Services, who is our auditor, and our work is guided by our HAI Advisory Committee, and our work is also guided by the NHSN in terms of any resolution of discordant findings. We always rely on NHSN. They have the final word, but we do have an auditor, and the auditor maintains certified infection preventionist auditors, and I think it's important that that you all be aware of that as well. In terms of our objectives, we want to look at the completeness and accuracy of the HAI data, but this project also entails investigating alternative ways to review the quality of the NHSN data without having to do on-site chart reviews each year. Now that we've expanded our data reporting requirements to remain consistent with CMS and the CMS Value-Based Purchasing Program and the Inpatient Quality Reporting Program and the Outpatient Quality Reporting Program, it's just next to impossible to do on-site chart reviews for all of these different HAI event types. So this project is a first effort to look at other ways to screen the data, to allow us to focus on areas that appear vulnerable in terms of data quality, areas that could be improved if there were system changes, and then areas perhaps that could be improved with further training to facilitate data quality improvement. We also see this project as a way of looking at HSCRC data quality. It's not a direct objective or a first objective, but it's certainly a benefit of comparing the HSCRC data to the NHSN data. It's important that I state here that we recognize there are differences in the definitions in the NHSN data versus the HSCRC data, but we found that this is definitely a process that gives us opportunity to direct and target our resources. In terms of our contracts, this is the 4th year of a 5-year contract with Advanta Government Services. Each of the years, as you can see here, we have completed on-site chart reviews, 2 years for CLABSI and then 1 year for SSI. This year, we're looking at quite a few data types, as you know. And going forward in our final year of the contract, our focus will be on education providing focused or targeted on-site reviews based upon what we identify through this initial data review process. And we hope to foster collaborative process improvement, creating opportunities for hospitals to learn from one another in terms of what they've done to improve the quality of the care. I mean, the quality of the data, but if there is an opportunity to improve the quality of the care provided, we certainly would want to take advantage of that. This slide reviews again that we are looking at the accuracy, completeness, consistency, and timeliness of the NHSN data. It is part of the what our focus is for this review process. This slide touches a bit again on the issue of using two different data sets with two different purposes and different definitions. So of course in the NHSN surveillance system, the definitions are designed by CDC for surveillance purposes. They are not always consistent with clinical definitions, or it's not always consistent with the way in which perhaps physicians would characterize a case, whether it's HAI or hospital-associated or HAI related. But the issue here is making sure that the IPs recognize that we understand that difference in their surveillance, where it's population-based, standard definitions. The data collection and analysis is for a specific purpose in terms of comparing hospital performance or comparing broadly statewide performance on various HAIs, and it focuses on the NHSN event as defined by CDC, whereas clinical information is collected, perhaps in this case more for the care of the patient, to support the medical record number, and the to support coding definition in some instances. The other area that I wanted to bring your attention to is the fact that CMS and CDC have issued a communique regarding their concerns on the quality of the NHSN data, and concerns have been raised by to CDC and CMS by NHSN users, where they may be getting pressure from either leadership in the facility or physicians to report through NHSN in a way that is not necessarily consistent with NHSN definitions, but are perhaps more consistent with clinical definitions or coding definitions. The purpose of this slide and the purpose of sending you that communique is that we believe that CMS or CDC will likely focus their resources or some resources in further investigating whether or not hospitals are complying with CDC protocols and definitions. So we wanted to just share that with everyone because it is important, because it is used, this data is used nationwide for value-based purchasing, for payment, and for other purposes, and that it's important that you recognize at the federal level that there may be some additional attention to HAI data reporting. You can see here, and if you read the communique that was sent to you, NHSN has the right to revoke enrollment if a hospital or a NHSN user knowingly violates NHSN protocol. And the Department of Health and Human Services is also focused on getting information from users of NHSN, from hospitals, IPs or others, on any challenge they may have with submitting in accordance with NHSN definitions. And they are asking, they've created a hotline for hospitals to submit any concerns regarding that. If there is pressure from hospitals with respect to ordering diagnostic tests in absence of clinical symptoms, or if hospitals or persons are discouraged from ordering diagnostic tests in the presence of certain clinical symptoms. So there is an effort at the federal level to really investigate further data quality reporting through NHSN. So the focus of the data review for this year has been surgical site infections, catheter-associated urinary tract infections, CAUTI in ICUs only, CLABSI in ICUs only, C. diff, and MRSA. So the data period covered here does not include an entire year, but rather 2 quarters for MRSA and C. diff, and 1 quarter for the other data events. So again, we were focused more on developing this alternative to random on-site chart review, and we selected 1 and 2 quarters worth of data from both the HSCRC administrative database and from NHSN to do that comparison. So I'll turn it over to Lillian Riegel from AGS to review the statewide findings at this time. Lillian?
Hi, and welcome, and thank you for attending. For SSI, during the SSI review, we found persistent potential over and underreporting. The rate of potential underreporting was higher than overreporting in both the SSI procedure and event data categories. NHSN defines the operative procedure categories by ICD, now ICD-10, but in 2014 ICD-9, and CPT coding, which reinforces the critical role coding plays in SSI reporting. The overreported procedures were identified when procedures reported to NHSN did not have matching ICD-9 CM procedure or CPT codes in the HSCRC data, or when a reported SSI event had no matching HSCRC data. Underreported procedures were identified when ICD-9, CM, or CPT coding for an NHSN qualifying procedure was found in HSCRC data but not reported in NHSN. For the SSI events, there were 5 potential overreported events. Potential overreported SSIs were only investigated for the most severe categories, which are the deep incisional, primary, and organ space, since this is data that was reported in literature. The potential underreported SSIs, and there were 246 of those, they were found using infection codes used previously for CABG and joint procedures, as well as colon and hysterectomy infection codes found in literature. And all these codes are included in your appendix. And our plan is to provide a list of ICD-10, CM, PSC infection codes after our initial list is reviewed by certified coders. So we want to have that looked over before you receive that list, so that moving forward with ICD-10 coding, you will have those to use for your surveillance. The next slide shows statewide findings for C. diff, MRSA, and then our coding findings for device-associated events. The potential errors found for C. diff and MRSA included over and underreported specimens and NHSN to submitted data from facilities when there were mismatches in that data. Potential reporting errors included I'm sorry, I repeated my same line twice. Let me go back. Since I already told you what the potential error category is, let me break it down to over and underreported. The overreported events are NHSN without HSCRC records and specimens not submitted to AGS for review. And there were about 10.6% of reported events in NHSN that facilities did not send lab specimens for us to review. Underreported events included non-duplicate and unique specimens submitted to AGS for review collected from inpatient locations, and these specimens were not found in NHSN data, as well as HSCRC records with C. diff and MRSA coding without lab specimens or NHSN records. And for those particular cases, we would investigate those on site and see if positive culture had been collected or positive specimen had been collected during the admission. And we added the last category because we knew we did not receive all the positive specimens that were initially reported, so we knew there was difficulty with some labs retrieving all their positive systems, all their positive cultures from their systems to submit to us to review. For the device-associated CAUTI and CLABSI, only coding assessments were performed for these two types on the NHSN reported events. These findings will be valuable to the health information services managers to encourage coding assessments on all NHSN reported events, not just device-associated. And all of these findings support the need for multidisciplinary process improvement efforts. Are we gonna do lessons learned? Okay, I wasn't sure if I was continuing or not. The next slide shows some lessons learned, and it's at the state and facility level. And by providing the line listed cases in the Excel workbooks that are on OneHub, these examples can help facilities identify process improvement needs and guide improvement efforts. And they give concrete examples and help demonstrate the need for interdepartmental and unit-specific responsibility delegation in HAI reporting. This slide talks about HAI data quality, and leadership oversight is key to improving the HAI quality, because the IC department has no authority to require other departments to recognize their roles in HAI reporting. It is unrealistic to expect that the IC department can be delegated sole responsibility for HAI data quality. As you see on the slide, key elements required to report HAI data are documented by other disciplines, and retrieval is often complicated by fragmented EMR systems. If these elements are inaccurate or unavailable, it can lead to over and under reporting. All departments have numerous responsibilities, so we chose the IC department and broke out some of their responsibilities into a pie. And as you see, one piece of their pie is HAI prevention, surveillance, and reporting. And other departments within your facility may not be aware of their responsibilities in the HAI data quality process. And so the question is do all departments in your facility have HAI slices in their pies? So it's usually easy for everyone to recognize that HAI prevention has shared responsibilities throughout a facility. But it's not always easy to see that data quality has the same multidisciplinary responsibilities. And you need to examine if the HAI data quality process is a shared responsibility within your facility. In conclusion, MHCC recommends the following: a multidisciplinary and interdepartmental review of HAI surveillance processes, and that involves identifying key elements, assigning responsibility, and organizing various teams because each event type has unique requirements. Also, NHSN online HAI educational resources are available, not just for the IP, but for everyone involved in these multidisciplinary teams so they can better understand their roles and the need for process improvement. And I think next is just our question and answer period.
So thank you, Lillian. What we wanted to do in this first segment of the webinar is just to give a high-level overview, particularly since we've invited personnel outside of the IP area. So we've invited finance and quality improvement persons. So we wanted to find out if, in fact, you all have any questions with what has been communicated here before we get into very specific and detailed results for each of the data types. But what we've attempted also to do here is to provide what we call potential errors, which means they are not actual errors at this point. This is what we would call suspicious data that requires further investigation because, again, you have clinical versus surveillance definitions. But we do believe this can be a good tool for us to start our focus on specific types of cases. So I believe we have a question from
Gwen Stewart is unmuted.
Gwen, do you have a question?
She just logged off.
Oh, we lost Gwen.
Right,
Come back.
she'll come back.
The other thing, was there another one?
Yes, Lisa Hargan.
Lisa, do you have a question? Lisa?
Gwen Stewart wants to know, could coding be a part of the under-reporting?
Absolutely. And that's what we're trying to, one of the things we're trying to stress here is that especially in SSI procedure reporting, coding is key. And if the health information services managers aren't performing QI on these surgical procedures and making sure they're being coded correctly, working with the surgeons, working with surgical services employees to make sure that these are being coded correctly, then the IP is at loss because she can only report what's coded. So yes, Gwen, that's one of the points we're trying to make.
And again, for those of you who are perhaps not IPs and you're thinking about what's the significance of some of these types of errors that we've highlighted here. For example, with the SSI, there were issues with the denominator in reporting in NHSN all procedures. And if, in fact, you're not reporting all your procedures, then your rate can look artificially higher than it would be. So, you know, it is in the hospital's best interest to ensure that all procedures are being reported. And sometimes there could be technical issues associated with how data is pulled into NHSN. But the real focus of what we're trying to communicate is the need for greater attention, if you will, from various departments to support the IP to ensure that the information is being made available in a way that the IP can report through NHSN completely and accurately. That is one of the issues that we found. We also know that some hospitals have established multidisciplinary teams to work on some of this. So we're not saying that hospitals are not doing it, but we know that there's areas in which some hospitals could improve. And the detailed worksheets that were sent to each facility will highlight where there may be some vulnerabilities. Again, these are potential errors using the HSCRC data as a screening tool only, but it's definitely a place to start, and I think it's an area where we found that going forward, we can perhaps provide information to the IP on either a annual basis or a 6-month or quarterly basis that will show what we're finding in the HSCRC file versus what's been reported in NHSN. Or it could be something that at certain hospitals you can utilize some of the information that we've included in the appendix to create your own screening tools. So you can also investigate the accuracy of the data, the NHSN data, at your own facility for those that aren't doing it already. So given the importance of HAI data reporting and knowing that CDC and CMS and others are raising concerns about its accuracy, we thought it was very important to have this webinar to share that information with you as well. And it also is part of our policy. As we public report any information, we either validate it through audits or we try to come up with some other ways in which we can review the quality of that information. Are there any other questions that have come through?
Yes. Lisa Hargett has a question about, could you please review or clarify how you defined underreporting for the lab ID event?
Okay, we do get that into more detail, but I will go back over that. Let me get back to my slide. And it was
the underreporting.
Okay. The underreported events, we first identified and separated out the lab data that was submitted from your facility. And we removed the non-duplicated specimens or the unique specimen. You know, we followed all of the rules and definitions for NHSN for screening those. And then what was not reported, what was left of those, and were reported from an inpatient unit or from an hospital-affiliated outpatient unit that was identified by your facility, and we had HSCRC admission data from the same date saying they were admitted on that day, then we also included those specimens in that pool. We also then, because we knew we didn't get from all facilities all of their positive cultures, we also included a review of HSCRC data looking for lab ID event coding, so a C. diff code or a MRSA bacteremia code. And those codes, like I said, are included in the back. And for cases and records where we found those codes, we included those also as a potential underreport. We don't know for sure there were any specimens collected, but we don't know that they weren't collected either. So that's why we included them. And it's listed on your worksheet as these cases would be investigated for positive culture collection during this admission. Does that help?
We have two other questions. Gwen Stewart wants to know is there less error for reporting with those facilities that have a data mining system?
Unfortunately, Gwen, we didn't have a list of the facilities that have data mining systems, so that could be something that we could aggregate for you and share. Once facilities could let MHCC know or let us know that they have a data mining system, and we'll all be happy to aggregate those for you. But since I didn't know, the errors seem to be fairly evenly spread through the lab ID event reporting. So I couldn't target a specific facility other than some small facilities that had low occurrence rates to begin with, low specimen collection, to target and say, oh, I can tell, these have a really good surveillance system in place. So if people want to let me know, I'll be happy to aggregate that data for you.
We have a question from Brian Meehan. And Lillian, this is on slide number 12, if you want to go back to that.
Okay.
And point number 2, can you explain how 692 potential errors are measured with 583 MRSA specimens reported?
Okay. Because we also looked for specimens that weren't reported. And that's where the underreporting is, which I explained. We do screen the lab data that was submitted to us to review, and in that subset, there were specimens that met the NHSN definition, but were not reported to the NHSN system. And also, we looked at the SCRC coding to again include that subset that had coding indicating a bacteremia or a C. diff infection, yet there was no specimens submitted for us to look at. So there potentially could have been additionally underreported specimens because we didn't receive them all from facilities as instructed. If that was not a complete enough answer for you, Brian, you can.
We do have another question. Shakana Cotton, I hope I pronounced your name correctly. She said that her facility has submitted cases that they believe fits the revised CDC definitions for review, but there have been times that it appears to fit the CDC definition, and then when reviewed by MHCC, it is not appropriate. How do we reduce wrong reporting?
I think that when you are kind of what we may call on the fence about a case, the first resource should not be MHCC, but NHSN. You should query NHSN because sometimes you may think you are understanding the reporting rules, but as we found through just the requesting data lab submissions, that some facilities admitted that, oh my goodness, I misinterpreted the reporting rules in 2014, because these rules for every different event type are very complicated and complex. And so I think that that is your first line of questioning is to NHSN, and to re-review online, because if you haven't done, I'm not sure how big your department might be, but if you are a sole practitioner, you are constantly doing the same surveillance. If you divide up your surveillance, if you're in a facility that does that, you may not have been looking at CLABSIs for a while, so you may need to refresh yourself. So if you don't have little cheat sheets for that, you can go online and just re-review, because everything is available on the NHSN website.
There's another question.
Shakana?
Lillian?
Shakana? Okay.
Hello?
Yeah.
Okay.
Hello.
This is what my concern is, because normally we do go to NHSN first, and when we don't get a prompt response, because we do put the data on our dashboard for display, and when I say a prompt, it could be a couple of weeks that pass before we get a response, then we go to MHCC. My concern is we do many root cause analysis on every CLABSI, CAUTI, any infection that falls out, especially on our units that are being tracked by HSCRC. So my concern is the last event that we had, our physicians didn't agree that it was an actual fallout. the ICU manager didn't agree that it was a fallout. And then finally, even though they disagreed, it fits the definition. So, I mean, it becomes a little bit sticky. And we have adequate, go ahead, sorry.
No, that's okay, finish.
So with that being said, each Klapsier Claudia can cost any organization upwards of $200,000. So you want to make sure you're not underreporting, and you don't want to make sure that you're wrong reporting.
Correct.
Yeah.
Correct. Well, first I want to congratulate you for your thoroughness and that your facility does root cause analysis on events, because not all facilities are doing that, and I really think that will help improve your processes.
Mm-hmm.
Second of all, I do understand the delay sometimes when you submit a scenario to NHSN and their review. They are trying to improve the review process so it isn't taking as long, and they have been hiring and assigning people very specific duties for those types of reviews. So hopefully moving forward that would be helpful. But yes, it can be concerning when you're not getting a response back. But I think I would withhold that finding until you did hear back from them. I think that would be your best case scenario. And I know it might fall like in between months or quarters when you're releasing your dashboard or whatever, but it would be better to hold it and then add it later and say this was actually discovered, you know, last month, but we didn't get a full review by NHSN until this month. So that's an option.
Thank you, Lillian. That will help. Thank you.
You're welcome.
I think we're ready to move on.
Okay, let me just respond to some concerns that we've received online regarding sharing of information with the CFOs prior to sharing or at the same time sharing with IPs. Our main purpose, as I mentioned earlier, is to pull in the finance-related persons and others so that they can see that there are significant complexities with reporting this information and that it is dependent upon various departments to actually fulfill the reporting responsibility. And we sent out the CMS directive to show that other states, other hospitals are having challenges in terms of submitting information in accordance with CDC definitions, because physicians and others may have a different perspective on clinically whether or not it meets certain requirements. So we know that's a challenge. But the purpose of really pulling in the finance people is to, in this early part of the webinar, is to communicate those issues with that group of people, and then we'll go through in the second half with the more detailed information for IPs. So we really are trying to find ways to support infection preventionists by pulling in other, like the finance, for example, in this case, so that they can recognize the importance of what you're doing. But it's definitely not to say we have found errors in your data and therefore we want to expose or highlight the vulnerabilities or limitations of the infection preventionist. That's absolutely not what we're trying to do here. So we're hoping that through providing additional information and expanding who we're sharing the information with and reiterating the fact that it is a multidisciplinary activity, that we can gain more support for infection preventionists and the work that's being done. That is our goal. So I wanted to make sure I reiterated that before we move into this next phase where we really get into more of the detail information on the specific HAI event types. Thank you.
Another reason why we included those pie graphs for you, because you might be able to use those to help demonstrate to some of your leadership who aren't in attendance for this, to emphasize that everybody needs to be involved in this process. It's not just an IC responsibility. Okay? think we'll go ahead and move forward with the next phase. You may need to shake your brain a little bit to get ready. There's a lot to cover. Data reliability has two components, denominator and numerator data. And denominator data identifies at-risk populations that can be determined by the performance and coding of specific surgical procedures, documentation of device insertion and removal, lab specimen collection location, as well as device and patient days and admission total. And as we know, all this can be complicated when the data isn't available, or it's available in formats that don't meet the NHSN requirements. Numerator data are the events identified and reported to NHSN. And although an event is determined by the IP, this process is dependent on information available to the IP for review and the correct interpretation and application of the NHSN definitions and reporting guidelines. Each event type has unique NHSN reporting guidelines and key element definitions. Misinterpretation of these definitions can result in over and under reporting. Often processes are not available to provide the IP with key reporting elements. Electronic collection processes incorporate current NHSN guidelines and definitions. And the NHSN does require any electronically collected data to be validated for at least 3 months with manual count before it is submitted to NHSN. And I know that sometimes that can be difficult. For SSI reporting in 2014, there were 6 specific procedure types that were included, and they're listed for you, and the subsequent surgical site infections that occurred within a specified time frame following one of these procedures. We'll do a general overview. This chart includes SSI, denominator, and numerator data reported to NHSN for the first quarter of 2014. And it's a breakout by procedure type, so you could have a peek at that. And we had 2 additions to SSI reporting since the last audit, and those were colon and abdominal hysterectomy procedures. And the addition of these procedures greatly increased the surveillance burden. And due to the high bacteria count within the colon, of course, this procedure type has a higher risk for infection than other procedure types. And this table shows that 16% of the procedures performed for this quarter were colon procedures, but those procedures accounted for 62% of the total SSIs and 54% of the DIPs and OSs associated with this one specific event type. And other infection rates for other categories are proportional to or less than their performance percentages. So even though people say, oh, we only added 2 more procedures, the burden has increased significantly for the IP. And it's also really crucial to make sure these procedures are coded correctly and that they are really colon procedures and not small bowel, or vice versa. Potential administrative procedure coding errors and NHSN reporting errors continue to be identified in procedure reporting. Potential underreported procedures outnumbered the potential overreported procedures. 95% of the potentially overreported procedures did not have ICD-CM procedure or CPT code to match the reported NHSN procedure category. The remaining cases either had no HSDRC data to match the NHSN submitted medical record number, or did not meet the 2014 NHSN definition of an inpatient. A potential underreported procedure was identified when an NHSN procedure category code was found in HSDRC data, but the procedure was not found in the NHSN database. The SSI events this slide breaks out the SSI events from just total and DIPS and OSs. And only the DIPS and OS categories are reported to the public, and therefore they were the focus of the potential over-reported SSIs. HSCRC data was missing or without index procedure coding for the 5 potential over-reported cases that we identified, which means there could have been an MRN discrepancy that wasn't obvious enough for me to make a manual match, because I did try to attempt to make manual matches for typos. And that in the past, that has been the most common finding for an over-reported SSI, was that there was some sort of typographical error on, on the NHSN data submission side. Potential underreported SSIs included all SSI categories, of course, because you can't distinguish whether they're deep or superficial until you do an actual review. The algorithm used to identify a potential underreported SSI recognized a potential infection after surgery. This algorithm proved to be less effective for same-state colon procedures, and that led to the exclusion of potentially underreported colon procedures during the same-stay total in the above table. We didn't want to be including numbers that we couldn't be as sure about, because it seemed to have a little less specificity for colon procedures, because there's a higher percentage of colon patients that can come in that actively have or could be coded for an infection on admission because they have a perf and things like that. So we can see how that coding can be difficult to screen for same stay as opposed to on a readmission. And again, I'll keep reiterating that those infection codes are in the back, but they, of course, were the ICD-9 codes, because that's what we used in 2014. And I hope to be able to provide to you soon the list of ICD-10 codes. Potentially underreported SSIs were found using these infection codes that we used previously from our last audit with CABG and joint procedures, as well as the new codes we could find in literature for screening for colon and hysterectomy. On this slide, there are 2 tables, and the top table provides a breakout of when the reported SSIs were detected. And of course, they can be detected during the index admission, readmission to the same facility, detected readmission to another facility, and detected in post-discharge surveillance. So when these events are detected outside of the facility, the index facility, they don't really qualify to be assessed for HSCRC admission stay verification. And so that's why it's broken out, so that you could see that not all the cases were eligible when we did this part of the review. But 96%, so almost all of the eligible events were verified with HSCRC data. And this was an improvement since the last SSI audit, and I believe it was about 92% at that time. So everybody pat themselves on the back, because we need that. As demonstrated in the previous SSI audit, HSCRC administrative data is very effective for detecting potential over and under reporting. However, we found the lack of specificity for detecting the potential colon SSIs during same stay, and this finding led to the decision to exclude them not only from the tables and the statistics, but also from your workbooks in OneHub. So you will not find those in your spreadsheet either. So, are there any SSI specific questions? We're going to take a break after every after every event type, because it does get a little overwhelming after a while, and you forget what you were going to ask.
Lisa Hargett has a question. are there plans to perform chart reviews of the underreporting SSI events, especially since this was based on readmission codes?
No, not for the 2014 data.
Correct. Right.
Okay, but moving forward, and that's what you can use this data to show your HIM directors. Moving forward, we suggest that you provide them a list of what you've submitted to NHSN, and they look and see if the coding's correct. And then they are responsible to investigate with the surgeons if their documentation is lacking, or is it a coding issue, that the coders are just not interpreting the operative reports correctly. Because you can't be expected to read every operative report and determine, because that's not complying with NHSN definitions. The procedures are defined by the coding. And I know a lot of you are so diligent, and you read the operative reports and you're like, oh, this isn't right. And because you're so busy, you can't get down to HIM and go, you know, they didn't code this procedure right. Nor should that be your responsibility. Surgical services, a team really needs to be involved and make sure that the procedures that they're performing are coded right so the reimbursement is correct. Okay, so it becomes a circle, and again, you need to bring in other team members, because you should not have to read every operative report.
We have some other questions. Barbara O'Connor, her question is, once we review our reports and resolve discrepancies, will the reports be rerun and sent back to us?
No, we're not conducting these as the same as past audits because we didn't validate the data. These are, again, potential or suspected data problems. And so use this data to help jumpstart your improvement projects and involve the departments that will need to help to better improve the data quality. But no, we're not going to redo it. However, Barb, since you did bring this up, if you do find, as we had discussed a little bit, that there were procedures that you reported to NHSN, but they're reported as an underreported procedure because they're not available in the NHSN data that MHCC was able to retrieve, then we need to know that from all hospitals so that MHCC can investigate why they can't retrieve all the NHSN data correctly, because as we all know, retrieving data from NHSN sometimes is extremely problematic. So please let us know. You can send either emails to Eileen or to myself or call me and let me know if you're finding that type of error, please.
Gwen Stewart has the question, how does the underreporting data compare with this process and the on-site process in past audits?
It's statistically about the same, which means despite recommendations, there's really no change. So I think that's part of why we're doing this webinar, to encourage leadership to follow some of the recommendations, and that now there are not only patient safety issues to address, but also financial issues to address. And as we know, often financial issues do get, leadership to stand up and pay attention. Unfortunately, that you have to have it work that way. But really no change.
Lynn, Karen Phil had a question about the previous slide, which I think would be slide 28. Are we only reporting colon procedures for those who are admitted?
Admission, no. Admission is not the term that's used by NHSN. So if you're going to talk about 2014 guidelines, in 2014 guidelines, they defined it as a procedure performed on an inpatient. And they defined an inpatient at that time as someone who had an admission date not equal to a discharge date. So in facilities, that would include some quote unquote, outpatients, okay? And I think that is where there was a misinterpretation of the guidelines. For 2015, NHSN was aware of that, and so they tried to make the guidelines more specific. Initially, they had you guys trying to identify outpatient locations for procedures, and they decided that was not helpful. So they went ahead and defined, again, an inpatient procedure instead of an inpatient. And so now the inpatient procedure is a procedure that's performed on a patient whose admission date is not equal to their discharge date. And again, that will include some outpatient. So you need to make sure that's in your electronic surveillance matrix, that you are not just scanning inpatients, but also outpatients that meet the NHSN inpatient procedure definition. Any other questions? And again, at any time, you know, not everybody likes to submit questions publicly. If you have any questions, please don't hesitate to call, send an email, okay? We'll move on to lab ID events, our favorite. Lab ID event reporting should not be confused with CDI infection surveillance. And I think we all kind of got clear on that definition. Only positive lab values and administrative data are used in the lab ID reporting process. So in lab ID event reporting, NHSN algorithms assign onset categories. And this was difficult for some facilities to interpret correctly, and some of them admitted that. MRSA specimens are assigned just a hospital or community onset. And I've highlighted in green the hospital onset because hospital onset, those numbers are what's used by NHSN in the MRSA SIR reporting, which is what's reported to the public. Of course, both event types, hospital onset and community onset, just as with C. diff, are used to report different prevalence and incidence rates. But for SIR reporting, the only number that they look at and include are the hospital onset cases. And so you can reinforce that to people who are saying, why do we have so much C. diff or MRSA? There is only one category that's looked at. Sometimes they're looking at total numbers and listening to a total number from you, and you have to really drill it down for them. And I thought that would be a good reminder. And we'll do a C. diff overview because the breakout is a little different for the C. diff. And C. diff lab ID events are first categorized by NHSN algorithms as incident or recurrent. And this is based on current specimen collection date and a prior specimen collection date. And then the specimens are categorized into hospital and community onset categories. NHSN, again, uses only the incident hospital onset events to calculate C. diff SIR. And the other categories are used for various prevalence and incidence rates, which are important for your facility and to know them. But the SIRs that are publicly reported only include that data set. For this event type, lab data was requested. And although some facilities submitted data without difficulty, we identified data submission challenges. And moving forward, we will include additional data submission support, templates, as well as outline specific departmental responsibilities in any future data submission request letters, should there be additional data requests. During the submission process, as I mentioned before, one facility did recognize that they had been misunderstanding the 2014 reporting guidelines and definitions. And they did go back and retroactively report their data, but we still excluded it from our review because it had not been submitted in the 2014 timeframe. We did a quick coding review for this event type also, and it showed that greater than 92% of lab ID specimens reported to NHSN occurred within an HSCRC admission and stay, and the infection coding was found in greater than 80% of the reported events. So since there was such a higher level of coding, that's why we were able to use that HSCRC data and say, oh, potentially they could have had a positive specimen that wasn't sent to us to review, and that's why we included them in the potentially underreported category.
Brilliant. Lisa Hargett has a question about that. Do you want to respond now?
Sure.
To clarify, the NHSN COHCFA definition, does that capture patients that have been discharged from your facility within the past 4 weeks? However, when entering lab ID data, it asks if the patient was discharged from your facility in the last 3 months. How do you handle that?
Well, that's handled through the NHSN algorithm, okay? When they're looking back for the 8-week window of time, they're looking for a positive specimen that has been submitted from your facility for this patient in that time window. Why they ask for the 3-month question on your data submission is that differentiates whether it is a hospital-affiliated component added to it. Because if we back up a slide, or maybe we didn't get to that slide yet. Okay, there we are. The community onset healthcare facility associated is another category unique to C. diff. And that's why they're asking that. Because if they had contact with a healthcare system within a time frame, it gets categorized this way, and therefore changes different prevalency and incident rates. Yes, it's a very complex process. Oh no, that was one. And although what I found the most interesting, and I'm sure you all did, that lab ID event reporting was developed to decrease the burden of infection surveillance. However, it is one of the most complicated processes that the IPs have to do. So I always thought that's an interesting way to decrease the burden, because to me it seems very burdensome. Okay, was there anything else? Or? Okay.
Actually, she'd like to leave this. You want to address questions at the end?
Yeah, we just have, I think,
okay.
Well, I think we just have, are we on slide 35? Because we did the coding review. Okay. So now we have the lab ID data review findings, and it's slide 35. This table represents the overview of the lab ID event findings. And column 4 and 5, I tried to break them out. And so when you add those two together, you get your larger totals that you saw earlier of 1812 for C. diff and 692 for MRSA. But I tried to put them into two categories that then I could break out, and we could discuss a little bit more about what was included in each of those categories. Because it does on this show you the potential underreported specimen and the volume of those that we did find. And that included both the specimens that we found to be not reported, and also the HSCRC with infection coding that could possibly have specimens collected during that admission. So that is that category. But it was the numbers there were significant. This first table further breaks out the NHSN to lab error category. And again, showing that 10.9 of all NHSN lab specimens were not submitted to us for review. And this indicated to us that the lab was unable to compile, either for you, a complete list of all the positive specimens, because they couldn't even compile all the ones that you reported to NHSN. And that is a big system flag. And that information to have leadership include lab and IT to create processes so you can retrieve data, because you cannot assess data quality if you can't retrieve it. And you can't retrieve it in its original formatting. The specimen matching algorithms that we used were based on the crosswalks, and modified crosswalks, which I created when submitted crosswalks did not contain the correct NHSN abbreviations that I could find that you used in submitted data, or did not have the correct lab abbreviations that were on the lab data that was submitted to us. We did attempt to do some contacting facilities and send them to try to update the crosswalks, and it was such a time-consuming process. We had only got a couple of them done, and we really needed to move it forward. So to the best of my ability, using available resources, like I said, the NHSN and the abbreviations that were on the lab data, that's how we did our matching. And I'm not sure that everyone has had time to look at their data yet. That was sent, to really go over their worksheets and to evaluate each type. But I tried to lay them out in a way that would be easy for you to identify what the problem was with that case. And like I keep saying, if you have any questions about that when you're looking at it, just pick up the phone and give me a call. Except for not right after this, because I'll be driving home in traffic. Okay, need to add that. But tomorrow morning I'm up by 6, so I'm good to go. Again, we have another breakout of the potential error category, which includes specimens without admission verification deficits, which means we couldn't find HSCRC data at all. Qualified specimens not reported to NHSN, and again, the HSCRC data with the coding. Laboratory specimens missing from the data set submitted by the facility in NHSN events with specimen collection and or admission date mismatches. So I did try to do as close to a match with a specimen that I could find. And sometimes they had both a collection date mismatch and a location mismatch, and sometimes they only had one of the mismatches. And although the NHSN reporting guidelines for lab ID events have changed for 2015, the data audit findings support the need for multidisciplinary process improvement for this event type reported. So now that's how we feel. Another break for questions.
Lisa Hargett, you're unmuted if you would like to bring your question up. The question that Lisa had sent during the presentation was the time frame is different from what is defined in the NHSN definition. So Lisa, if you want to try to type in a longer question, that would be fine. We can still bring it up to the group.
Yeah, Lisa, I'm not quite sure which time frames you're referring to. Address that. Okay.
Okay, M. Clance, I'm sorry I don't have your first name, but I'm going to unmute you. Would you like to bring your questions to the group?
He's coming over. Hold on just a second.
Oh, okay, perfect.
Yeah, hi everybody. This is Mary Kless from Anne Arundel. Beth Christie and I were wondering about obtaining a quarterly line list of any potential discrepancies regarding the HSCRC and HSN data submissions. We really need some feedback if there's issues regarding underreporting. I guess I want to add on to that because I'm trying to understand how you're doing this, and I really would like maybe a couple of months of what you're looking at so that I can look at it too. I'm just having, I don't know if anybody else is having a hard time, but I'm just having a hard time visualizing how you're getting the information and crosswalking and all of that. I'm so sorry.
Okay, so we'll address the first issue, which is you would find quarterly reports, if possible, very helpful, especially in underreporting. And I think that that's one of the goals for this year for MHCC to develop processes that would allow for that to happen. So that, yes, in a more real-time world, you could find out that, oh, wait, we could have missed some procedures. And so that is moving forward what MHCC intends to do.
There's another point we need to raise here, and that has to do with timing. When the HSCRC data is available, and then we have to wait for that data to become available before we can do the comparison on a quarterly basis. But it is encouraging to hear that perhaps some hospitals will find this useful to get information on a quarterly basis to kind of give a sense of what they may want to focus their attention on.
I agree. I mean, if we're having issues, we might not even know that we're having issues. Do you understand? I've gone through data validation before in DC, and we found that there were issues in locations and how locations were where you guys were getting your information and where we were getting our information. Does that make sense?
Correct.
So, if we could identify them, and fix it for the upcoming data sets if we can't fix the past.
Did you say you wanted a better understanding of the process, how we've gone about doing this? Can you go over that?
Yeah, that's what I was going to go over. And one of the things that might be helpful on your worksheet is that if you did have a lot of location mismatches, you might need to evaluate, did you really, is there a communication between you and the lab? And have those locations been mapped correctly, and are they aware that these locations are locations you're reporting to NHSN? Because that needs to be shared. Because we could tell that in the lab data we received, the lab location might say, it might be a room number, 239. But on the crosswalk that was submitted to us, it said CCU for the lab abbreviation location. And your submitting to NHSN location was CCU. But that wasn't how your lab reports out the data. And so I think that's a learning process for many facilities, that what you thought was going to be on the lab data for us to see did not match what was on your crosswalk. And so that's something to go back and reevaluate also, so that when another data submission is requested, that the crosswalk that's needed is available. Because the crosswalk is necessary because we have NHSN data and we have lab data. But the lab data from your facility does not have NHSN locations on it because your lab does not use NHSN locations. So they'll only have their lab facility-specific lab abbreviations. And so you do it mentally when you look at your lab. You crosswalk in your brain and you go, oh, these room numbers are on CCU. And so they're into your CCU pile. But when you're looking at two independent data sets, you have to have something to crosswalk that information with. And when that information wasn't correct, what I tried to do to the best of my ability was look at the submitted NHSN data and say, oh, okay, this specimen was reported to CCU, and I'd go to your lab data and I'd find that specimen and I'd say, oh, but the lab abbreviation is not what they put on their crosswalk of CCU. It's actually this group of room numbers that I could identify based on me manually matching the specimens. And from that, I created a crosswalk so that the computer algorithm could match these specimens. Okay? Does that help?
Mary had also sent in 2 other questions, and so just to make sure that your question is answered about getting a line list of events in which there is a discontinuity between the codes, the HSBRC data, the NHSN data. I think Lillian just addressed that in a sense.
Well, additionally, Mary, the worksheet that we did send you, the line listing spreadsheet, do have individual line listing with coding on some of them as far as your procedures go. That's on OneHub. Those instructions were included in your facility report, and you have to go onto OneHub and you can see your worksheets.
The IP would be able to, she can get that from the IP.
Okay.
Yeah.
I am the IP and I didn't get it.
Mary Clan?
So that's, Dr. Hospital epidemiologist, she didn't get that, and I didn't get that. And I'm the director of infection prevention. I'm not sure where it got sent to.
Yeah, who is the feedback going to?
It's placed in the OneHub, and the contact, we have one contact for each hospital. The infection preventionist contact is the person it goes to. We don't have the list in front of us, but we could.
For Anne Arundel, I know it was recently updated, but I had copied Anne Van Watt as well. So I'd have to check who the new contact was that she asked me to send it to, but Anne Van Watt should definitely have access. But I can double check.
I'll get it. I'll try and get it from her. But yeah, I'm.
And I'm sorry. What's your name?
It's Beth Christie. And
okay,
we don't need to do this now. You know, we'll just get together after.
Okay. Yeah, I'll touch base with you. Thanks.
Thank you.
I think that once you see that, that will really help clarify a lot of what we've been saying.
I agree.
Lisa, your question about time frames.
Did you ask a question? We didn't ask about time frame.
They didn't ask about time frame.
Oh, okay.
It was Lisa Hargate. Okay. Hargate, still with the time frames. Lisa isn't able to get through on the telephone. So this goes back to the original question about clarifying the NHSN time frame, where it's 4 weeks versus the 3 months.
So you're still asking why they're asking you the question of 3 months. I guess that's what you were.
There was an email. That's not the caller now.
Oh, okay.
Yeah. Speak that she can hear.
Oh, okay. I keep forgetting she's not on the phone.
She said she'll email you, Lillian.
Oh, okay. That'll be great. That'll be fine. Any other questions? Everybody take a deep breath.
The hard part's coming.
No, just another.
CAUTI and CLAPS event reporting also has 2 components, denominator and numerator. And in 2014, device-associated reporting was required for critical care only. And as we know, the 2015 reporting includes all NHSN identified inpatient locations. Unlike SSI, present on admission criteria does apply to these device-associated reporting. only a coding analysis was performed for this event type. But there are several points to mention because NHSN has mentioned them several times also throughout the year. And that is in reporting patient and device day totals. You have to make sure that if they're electronic, they are snapshot totals and not 24-hour totals. Because if they are 24-hour totals, they are not meeting the NHSN definition or collecting them at the same time every day. They want actual counts at that specific time, not for the 24-hour period. And if you're reporting 24-hour totals, it changes the dynamics of your infection rate and your utilization rate. And so an example is 24-hour electronic totals are compiled at midnight each day by your facility for device and patient days per unit. This is not the same as the total number of patients on each unit at midnight, and of those patients, the total with devices. Okay, so you have to make sure that your electronic surveillance systems are adhering to the standards that NHSN sets for these definitions. Otherwise, data is skewed, and your data isn't really comparable to other facilities or can be falsely diluted, or the opposite could be true. So you really need to make sure that all electronic methods are validated with your manual count, and that any electronic programming has to capture the data as defined by NHSN, not just how the facility is collecting it. It has to be done as defined by NHSN. In the 2014 CAUTI event, reporting was required for all critical care units, excluding neonatal intensive care units. And even in 2015, all inpatient units, except for we're still excluding and will continue to exclude the NICUs. And I just want to remind people of that. And as part of this review, there was a decision made not to request laboratory data for these event types as part of this data quality audit because there have been difficulties in submitting the lab ID data. So instead, we just did a coding review, and admission data was verified in over 97% of the device-associated events, and cases with admission verification were further evaluated for critical care stay, coding reflective of an infection, and in device insertion coding. The total number of CAUTI reported to NHSN was 151. But on this slide, you see 147, and that is because 4 did not have matching HSCRC data. Therefore, you can't evaluate the coding in data that's non-existent. So then there's a breakout of the coding findings. Clinical definitions, which guide the assignment of ICD-9 CM codes, differ from the NHSN surveillance definitions, which guide the reporting of NHSN events. This is a factor because it decreases the percentage of reported events with an infection code and diminishes the value of administrative data use in predicting over and under-reporting device-associated events. However, improvement of device insertion coding would increase the value of administrative coding. Again, these coding findings are, to an IP, you say, I don't do coding, and we understand that. But these findings should be given to the Health Information Services Manager to use for comparison after a coding quality review is done of charts of patients with 2015 device-associated events reported to NHSN. And then they can use this comparison to see if they had any coding improvement from 2014 to 2015. And we did find it very surprising that only 3% of the CAUTIs had coding for an actual Foley insertion. We weren't surprised that the ICD-9 codes that are specifically associated, the infection specifically associated with the device, was not coded, because the coders can never assume a relationship exists between a device and an infection, and it must be specified by the physician to be coded. So if it's not specified by a physician, it will not be coded. But the device insertion should be coded, and it's either a lack of documentation to support the insertion, or it's the coder not picking up the proper documentation that is in the chart. And like I said, if we have that information, that could help as a screening tool along with culture results to help better get a subset of patients to even look at. Now that this has gone house-wide, you could at least say, at least we know these patients had devices. But as you know, that's a little bit easier for the central line because that is 77%. But for CAUTIs, it's only a 3% finding. So please forward this information and involve leadership, and so that HIM will become involved in this process. And I think overall it might be helpful for everyone. The role of HSCRC administrative data in identifying these potential device-related errors is limited, as I said, and it's not a new finding. But we still went ahead and processed it to see if coding, insertion coding had improved. And CLABSI insertion, central line insertion coding did improve some. So there was improvement for that process. And I think that because it is charted usually in multiple places and by multiple providers, that's why it's coded more readily. Where the insertion of a Foley is usually a nursing documentation, and I'm not sure how that is impacted in coding at the for Health Information Service. HSCRC administrative data, like I said, may have more usefulness for CLABSI validation because of the greater consistency in coding the device insertion. And although house-wide reporting for these events started in 2015, future audits for these event types will likely include critical care populations since they represent the highest risk populations and a subset of the med-surg population. We'll start into some recommendations. And we just wanted to attempt to include some bullets that might be beneficial for you to use to help other departments jumpstart their participation. So we won't go over every single bullet, but some of these bullets you'll be able to use to help with your process improvement efforts. Recommendations for all event types include the incorporation of best practices for prevention, unit-based ownership of denominator data collection and process improvement measures, as well as Health Information Services understanding the role of coding in HAI reporting. And need to reinforce to IT that the fragmented EMR system can really undermine data quality, and that they really need to work to improve their network communication, because I know many facilities have communicated that is the problem. Of course, identifying all the stakeholders, since each event type has a unique set, it might be helpful to actually list them per event so that you can communicate to leadership, these are the people that need to be on these teams to make progress. And then to require education using the online resources for all the participants, because that's the only way they're going to understand all the requirements. Communicating electronic report requirements to IT can be challenging because we know what we need, we just don't know how to tell IT. And so NHSN also has IT-specific resources available to IT professionals so that they can talk in their own lingo that is sometimes something that we really don't want to have to learn. Only after the department managers and educators and IT are trained can they understand the importance of all the key elements and develop their processes to ensure accurate documentation, archiving, and retrieval to improve data quality. Here are some specific recommendations to improve SSI reporting. A surgical services team needs to lead SSI process improvement. It's got to be a unit-based initiative. And of course, the IT needs to be a member of the team and provide resources. And procedure coding deficits must be addressed by health information services, managers and coders, medical and nursing management, and the electronic systems representatives. They need to be involved also to make sure all the procedures are captured in your electronic system. And that includes your quote-unquote outpatients, that their procedures qualify as inpatients. The IEP should provide the most current NHSN ICD-10 now, CM, PSC procedure mapping to ensure capture of all the procedures. They have to have the solid blocks, so then they can build a process around that. And as we know, these the mapping that's currently available has been updated once and is going to be updated again because there are some deficits in, as an example, in the knee procedures. There were some procedures left off of the list, and NHSN does plan to do another update. To improve SSI surveillance, IT should develop electronic reports that print automatically for IPs to augment other surveillance techniques. Post-discharge surveillance is time-consuming and often yields poor physician compliance. The medical staff office should assist with this process and to improve the physician compliance with returning surveys and stressing the importance of it. And I think if the medical staff office will take control, you might get a little better compliance with your post-discharge surveillance. After an SSI is detected by the IP and determined to be that, the surgical services team should perform a review like they're doing at some facilities for event types and be responsible for maintaining unit-based statistics and present these statistics and quality improvement progress at IC meetings, helping to ease your burden a little bit. You're still involved in the process, but they need to take ownership. Otherwise, I'm not sure you'll have a lot of improvements, where the improvements will be at a much slower pace. Lab ID event reporting is complicated to say the least, and it's very time-consuming, and despite the intention to decrease the burden by removing the clinical component. Reporting quality data requires a solid understanding of the reporting guidelines and definitions, and when you're in doubt, you need to query the NHSN because they are the experts. But all of these definitions need to be understood by all of the departments involved for this event type. And because only with multidisciplinary support and accountability for data elements can the data actually have accuracy. Data retrieval challenges were evidenced by the decreased ability to reproduce NHSN reported lab data. And we hope that the recommendation bullet on this slide can help your facility in their efforts to improve lab ID, HAI data quality. Because without the lab involvement and making sure that they're actually storing your specimen collection location correctly for you to be able to retrieve it, your data will never, any data that we request from your facility will never match what you reported in NHSN. And as I put on some of the worksheets for people that did have multiple location mismatches. I asked the question, is this actually archived correctly by the lab, or is it archived and only retrievable and designated to the last location that the patient was physically in at the time of discharge, which I know is a problem with some systems. So in conclusion, MHCC intends to coordinate an increased interdepartmental participation at the facility level and promote interfacility collaboration to share process improvement ideas.
Did you skip a slide? What was it? Device associated?
Did I miss one? Oh, I'm so sorry. Sorry about that, guys. Am I in a hurry to get done? No. This has been a very long project. So time to laugh and get that energy boost. I skipped right over the device-associated event collection. Unit directors should be responsible for documentation to allow for accurate electronic capture of this data, and also for manual records of denominator elements when electronic capture is not possible. Again, we're down to unit-based ownership and responsibilities. These should be PI projects on a unit-based level. They should be monitoring how many devices they have, how many infections they have, and really participate in these efforts. And just the basic documentation of all of the elements you need to report these, vital signs, signs and symptoms for device associated. Often you can't find things reported in the medical record, and if nursing management isn't aware of it, they don't know that these deficits exist for their unit. Some facilities can explore the use of the weekly device day reporting, and I don't know if anybody out there is using it. If you are, during question time here at the end, why don't you share that with us? But also caution, make sure that this option is validated for you before you begin to do this, because underreporting device days will negatively impact your infection rate. So you want to make sure that that's accurate and not underreporting, because it's going to fall back and look like you have higher. So just make sure you validate that that's going to be a process that's accurate for your facility or a certain unit, and then go with it if it is. Okay? Now we'll conclude. And as I said, the main intention of this review and for MHCC is to just encourage and foster interdepartmental participation in facilities, but also between facilities. And that if you have teams that you've already started, share with other IPs at APIC meetings how you got that ball rolling and some of the stumbling blocks that you overcame and how you overcame them. And that will help other facilities be able to initiate their teams. Also included at the very end of these slides is an appendix, and it includes abbreviations, infection codes, and the review processes specific to each event type. And we want to thank you for your continued support of the HAI data quality improvement effort. And are there any additional questions and concerns?
We have two questions from Lee Chapman. And the first is, what is the timeline for the NHSN update? The other question is specific to slide 41.
Now, which NHSN update are you talking about? The ICD-10 codes, I believe. I had heard from Janet, and they were hoping to have that out before the end of the year. And I'm sure they're working on that, because starting in 2016, the NHSN system will accept those codes. So I think they're trying to get that out before the end of the year. But also at this time, they're also trying to get out all of the changes for 2016 and all event types. So, you know, I think the crunch time is on. But in the last email, which was the beginning of October that I got from her, she said they were hoping to have it out by the end of the year. So that's all I know to date, Lee. And then which slide?
Slide 41. The question is under the UTIs that are coded in the HSCRC data. Is that PPC 65 just UTI or 66 CAUTI?
No, it is just the UTI code. That's why we did at least break that out to show that they are coding a UTI. They're not coding CAUTIs. That's your column 5. That's your code 996.64. And I put those codes in there so that HIM would have those specific codes that we looked at. And those are specific. That is the infection related to a urinary catheter and bloodstream infection related to a central line. So those are very specific codes. But we wanted to include the UTI code because they are coding that they do have a urinary tract infection. And as we said, because of clinical and surveillance definition, there may not be enough documentation to support from the physician that the infection that they have is actually related to their urinary catheter. Was there anything else?
No.
And feel free, like I said, you can email me questions. You can call me. I'll be happy to help you, work through your worksheet, so just give me a call.
Your phone number? No.
It's on the sheet.
Thank you.
It's on the report. The phone number.
Yeah, my phone number is on the report, but I can give it out too. It's 301-432-4870 because lucky enough I'm working from home right now. So.
Great. No more questions?
No more questions.
Well, thank you, Elaine. You did a great job. That was a lot of information you covered in this period of time. I again want to thank everyone for participating in the webinar. As Lillian said, she is available to answer questions. Each hospital should have a spreadsheet. That spreadsheet should have been downloaded through OneHub. If you don't have that information, then contact Eileen Witherspoon and she can follow up for you. I also want to thank Karen Smith, the project director for the Advanta Government Services Group. She's been great, and I know that this has been a very long process for both of you, and we appreciate it. And we really hope that the hospitals can benefit from this process that has been developed. We'd like to, next year, under the contract, provide the same type of information to hospitals, perhaps on a quarterly basis, after we work with HSCRC to see what the timing will be in terms of the release of the HSCRC quarterly file. So I also hope that you recognize that we're trying to support the infection preventionists at the hospital, and if there is some other activity or effort that we could do, please let us know, because we want to move forward this effort. We recognize it is complex and definitions are changing and protocol changing. So, and also our contractor is willing to do on-site consultation, so please let us know. We will also look at the results to see if there are certain hospitals that we should reach out to proactively based upon their results. But again, feel free to contact us if you have any questions regarding this. And thank you so much for your participation. And hopefully we will be communicating soon on the next data quality review process. Thank you.